Hello, my name is Ian, and I'm doing a presentation on renal imaging, aka your genitourinary system. Sorry, I butchered that, but we'll continue on. So first, I wanted to take a look at the anatomy of the renal system. Basically, the function for this system is to regulate bodily fluids through excretory functions or create urine. So you have the two kidneys, the ureters, and the blood vessels attached at the hilum of each kidney. And then on the kidneys, you have an outer cortex and an inner medulla. The cortex contains your nephrons, which are the functional units of the kidneys, and then the medulla houses the renal pyramid, which empties urine into calyces of the renal pelvis. And inside those nephrons, microscopically, they contain renal corpuscles, the glomerulus, the Bowman's capsule, a proximal convoluted tubule, the loop of Henle, and a distal convoluted tubule, which we'll get into on the next slide. You see I got a picture of the nephron there. And basically this is where most of the physiology comes into play for urine formation of this system. So we have three different processes to go over. We have glomerular filtration, tubular reabsorption, and tubular secretion. So the first one involves filtering water and solute out of the glomeruli into the Bowman's capsule, and this is where we can get a GFR, which is the volume of the plasma filtered in 1 minute by both kidneys' glomeruli. And the second process involves renal tubules in the collecting systems. They both reabsorb important substances back into the blood, and then tubular secretion finally secretes substances out of the blood and into the filtrate, resulting in urine. The urine created from these processes pass through renal calyces, like we mentioned before, the renal pelvis, ureters, and finally into the bladder by peristalsis. If I can just, okay. And then now we can get on more into what you'll see in clinicals. Some clinical indications and contraindications of renal imaging include the functional evaluation of blood flow, renal function, obstructive uropathy, renal transplants, kidney donor function, and renal vascular hypertension. Some morphology indications include renal trauma, congenital abnormalities, and evaluation of contrast media allergies. And this just kind of refers to static imaging. And then we have some contraindications, which include contrast-induced acute tubular necrosis and any drugs that block tubular secretion. Now, some prep for renal imaging. Since there's so many different procedures, I kind of wrote this as generally for every procedure that you'll probably need to know. Because again, for example, okay, so we're going over like the medical history of the patient. You need to know the diagnosis, because if there's a diagnosis of, say, they're looking for hypertension, then you're going to want to look into using a procedure involving ACE inhibitors. Or if you're evaluating like kidney transplant function, then you'll want to do something more along the lines of renal, the function imaging. So you just want to go over the medical history with the patient beforehand, and then we'll go on to further prep as we continue on with the presentation. The radiopharmaceuticals used in this in renal imaging include they're all technetium-99. We have DTPA, MAG3, and DMSA, along with free tech. DTPA is used for that glomerular filtration, for measuring blood flow measurements, I guess, yeah. And then MAG3 is used to measure effective renal plasma flow, since basically each one's for each of those processes we discussed in the physiology section, where the radiopharmaceutical is used in those specific processes to measure different things. And then you have DMSA, which is used for imaging lesions or renal anatomy. And then we have the free tech used for testicular imaging, because, when we talk about this system, oftentimes we may forget that the bladder and the testicles, are involved in this system. So, and then I laid out a table there for you guys to view for your studying purposes. Again, each facility is going to have their different type of procedures, their ways of their doses, different ranges that they like to use. So take this with a grain of salt, but this is from Steve's review, so it's a good studying tool for sure. And then first we start with renal perfusion imaging. So what we're going to be doing here is for the patient, you're going to position the patient supine with the kidneys in the center of view for posterior pictures, and then you'll inject 10 to 15 millicuries of your chosen radiopharmaceutical as a bolus using the bolus method, and then obtain flow images as directed by your facility. And then, some normal findings from this would be the tracer arriving in each kidney at similar times and then excreting at similar times. But some abnormal findings would be if there's any decreased activity during this flow sequence, which may indicate cysts or vascular tumors, or if there's any increased activity, may indicate some arterial venous malformations. And also, it is key to keep in mind that if a patient has a renal transplant, you should make sure to position the camera over the right or left iliac fossa. Now we come upon renal function imaging. This is going to involve the use of renograms, which is a time activity curve which includes a vascular phase, a secretory phase, and an excretory phase. And for this procedure, the patient should void before and be well hydrated. And it is either performed with technetium-99 DTPA or MAG3. And you should position this patient for posterior images, administer the tracer via an IV, and then you should obtain a dynamic flow study for 20 to 30 minutes and administer Lasix to rule out any ureterial obstruction if the tracer doesn't clear from the renal pelvis prominently. Some normal imaging would include on this renogram, right? We're taking a look. I included a picture of a normal renogram. You'd see a high spike in uptake, usually your peak uptake in between 3 to 5 minutes, and then renal, pelvis, and bladder uptake by 3 to 6 minutes, and then a sharp decrease as the excretory phase occurs. But some abnormal images would not include that that cliff, as you can see in the normal one. And this could indicate some type of obstruction, or if there is just a low amount of uptake throughout each phase, then it could indicate poor renal function. And now we get on to like diuretics. So this is probably the one we see most often, and this is used to rule out any urinary tract obstructions. And this is a diuretic is given if tracer uptake is retained in the renal pelvis or calyces. And the one we're most familiar with is probably Lasix or furosemide. Sorry about that. And usually you would give this at a range of 20 to 40 milligrams for adults or 0.5 to 1 milligrams per kilogram for pediatrics. And you're going to want to inject this slowly because it's going to make the patient feel like they have to use the restroom. And hopefully the patient can hold it in for the study, but if not, usually they have to come off the camera and then post-void images would be taken. And you would acquire this data the same way that you would as the renal function study like we mentioned before. Now we get on to ACE inhibitor studies. So I included an image of kind of like what the ACE inhibitors, the physiology behind it. But these studies are used to diagnose renal vascular hypertension due to renal artery stenosis. So basically, ACE inhibitors block the creation of angiotensin II from angiotensin I, which if a patient has an abnormal renogram from this study, that may indicate this renal vascular hypertension. So some prep and some considerations to keep in mind are that if they're on ACE inhibitor therapy, this must be discontinued for 3 to 7 days. They must be well hydrated, and of course they must void before getting onto the camera. And as we're doing this study and before this study, their blood pressure and heart rate should be monitored because the administration of ACE inhibitors may affect their blood pressure. And the most common ACE inhibitors we see are captopril and enalapril. And as you can see, we would use 25 to 50 milligrams of captopril or 40 micrograms per kilogram and 10 milliliters of normal saline for the enalaprilat. And captopril is administered orally, and the tracer would be injected at 60 minutes after administration. And then for the enalaprilat, this is administered slowly over 3 to 5 minutes, and then tracer is injected at least 15 minutes after administration of that enalaprilat. So for cystography, I think this one's pretty interesting. Since I've been doing clinicals at Sunrise, I've been able to see this pretty often. So basically, this is done mostly on children, just to check for any reflux from the bladder back into the ureters. So there's two methods to do this. I haven't seen the indirect method where you would inject MAG3 or DTPA and then ask the patient to void while being imaged. Um, what I have seen is the direct method where basically it's kind of sad to watch sometimes because the kids, of course, they don't, one, like having an IV started on them, which you have to do first, and then two, they don't like to have catheters put in. Sometimes they're put to sleep, and then you have to have a doctor come in and do that. I've only seen that once, but of course, it's being in medicine, we have to get used to these sort of things, and I wouldn't say never necessarily become numb to them, but just make sure to control the room, if that makes sense. Because I I feel like it could get really easily. It could get out of hand if you don't make sure everybody's on the same page and everybody's doing their part to make sure that the kid is as comfortable as possible and um, that you're still getting the study done efficiently. But some normal findings that we'd find with this study is if there's increased activity in the bladder without any reflux, again, that would indicate that there's none going back into the ureters. And of course, an abnormal finding would be if there is indeed reflux into the ureters. Now we come upon testicular imaging. I haven't seen one of these, nor I don't know if we'll ever will, but it is still there. And we are looking for any testicular torsion or epididymitis. So for acquisition, you want to place the patient in a supine position with the penis taped to the pubic symphysis, and then the scrotal sac is supported by towels to be placed anteriorly to the camera. And after all that is said and done, you would inject the tracer, which is 5 to 15 millicuries of that free tech, and then take your dynamic imaging. So some normal findings would be, again, symmetrical activity distribution in the scrotal sac. Some abnormal findings would be well, for torsion, it would be less activity on the affected side of that torsion, and then it's the opposite for epididymitis, where you'd see increased blood flow to the affected side of the epididymitis. And yeah, I hope this has been beneficial for your studying, and I wish you guys all the best of luck for your board exams, and we'll see you guys in class. Thank you and have a good night.